Welcome to this high-yield guide on the management of Parkinsonism, tailored specifically for postgraduate psychiatry residents. Effectively managing this condition requires a structured approach to distinguish idiopathic Parkinson's disease from secondary causes and Parkinson plus syndromes. We can organize our management strategy into 5 clinical patterns. First is the initiation filter, where the primary rule is to treat the patient, not the disease. Management is strictly symptomatic since there are no proven disease-modifying therapies. You must consider the functional threshold. If a mild tremor or rigidity does not interfere with activities of daily living, employment, or social engagement, pharmacologic treatment may not be necessary. Be aware of early start risks, because initiating dopaminergic therapy too early, especially levodopa, increases the risk of long-term complications like dyskinesias. Always rule out secondary causes before starting therapy. Ensure the symptoms are not drug-induced by medications like antipsychotics or metoclopramide. If they are, the primary treatment is discontinuing the offending agent. Second is the pharmacologic ladder. Once symptoms become disabling, you select a medication based on the patient's age and predominant symptom. The gold standard is levodopa combined with carbidopa, which is the most effective treatment for bradykinesia and rigidity. Carbidopa is essential to prevent peripheral side effects like nausea. Dopamine agonists such as pramipexole, ropinirole, or rotigotine are often used as initial monotherapy in younger patients to delay levodopa complications. However, you must carefully monitor for daytime somnolence, peripheral edema, and impulse control disorders like pathologic gambling. For a tremor-predominant pattern where tremor is the only disabling feature, anticholinergics like trihexyphenidyl may be used. These must be strictly avoided in older adults due to the high risk of confusion and memory impairment. For early or mild support, MAOB inhibitors like selegiline and razagiline, or amantadine, can provide minor relief. Third is the Motor-Fluctuation Map, which addresses the on- and off roller coaster that typically develops after about 5 years of therapy as the brain's ability to store dopamine diminishes. You will frequently encounter the wearing-off phenomenon, where the levodopa effect fades before the next dose. This is managed by increasing the levodopa frequency, adding a COMT inhibitor like entacapone to extend its half-life, or adding a dopamine agonist. You may also see peak-dose dyskinesias, which are involuntary dance-like movements that occur when dopamine levels are highest. You can manage this by reducing the levodopa dose or adding amantadine. Freezing of gait, a sudden inability to move the feet, may respond to higher dopamine doses or sensory tricks like visual and auditory cues. Fourth is the non-motor symptom triage. These symptoms are often just as disabling as the movement disorder and require regular screening. For psychosis and hallucinations, first reduce and simplify medications, stopping anticholinergics and amantadine first before considering adding quetiapine or clozapine, keeping in mind to monitor the absolute neutrophil count. For dementia or cognitive loss, use cholinesterase inhibitors like donepezil or rivastigmine. Orthostatic hypotension is managed by increasing hydration and salt intake, or adding midodrine, fludrocortisone, or droxidopa. REM sleep behavior disorder responds well to melatonin or low-dose clonazepam at bedtime. For depression and anxiety, SSRIs or SNRIs remain the first-line treatments. Finally, the fifth pattern involves emergency and refractory options. Parkinsonism hyperpyrexia syndrome is a medical emergency caused by the sudden withdrawal of dopaminergic medications. It clinically mimics neuroleptic malignant syndrome with severe rigidity, high fever, and autonomic instability. The management requires urgent intravenous hydration and the immediate reinstitution of dopaminergic therapy. For advanced refractory cases, deep brain stimulation involves surgically implanting leads into the subthalamic nucleus or globus pallidus interna. It is indicated for dopamine-responsive patients suffering from disabling motor fluctuations, but is contraindicated in patients with significant cognitive impairment or severe psychiatric disease. Additionally, advanced delivery systems like duodopa intestinal gels or continuous apomorphine infusions can be considered for severe fluctuations.